We're on.
To season 2, episode 3 of Transformation Weight Control podcast.
This is episode 4.
Episode 4. My apologies. That is Alex Tuschinski, my co-host and tech person. And without him, this would never happen because it took me 6 months to learn how to use Zoom. And Alex does this like nothing. So we have a very special guest this evening, Dr. Robyn Pashby. I'm going to talk a lot about her in a few moments, but just to let you know that do not change podcasts. Do not click away because you're going to hear things that you have not heard if you struggle with the chronic disease of obesity. Dr. Pashby has a perspective on this that I am guaranteeing you that you have not heard before. She and I are in lockstep. When I met her I saw her on a video, and then I got in touch with her and we did a Zoom call, and it was apparent in like 3 seconds that we were on exactly the same page. She's got a heart of gold and she's very smart and has done research and everything else. So it's going to be a great podcast. So don't tune away because you'd be doing yourself a disservice. So let me introduce Dr. Pashby. She is a clinical health psychologist, and she is founder and director of Health Psychology Partners in Washington, D.C. And we discovered that we know 1 million people. And she worked with a physician named Dr. Arthur Frank, who I knew very, very well. He unfortunately passed, but he was an icon of the obesity world for many years. He had started a practice, and she sort of stepped in and took it over, I guess, is really the story. It's in Washington, D.C.
Yes.
What's that? What?
I helped, yes.
You helped, yeah. So if you're in the Washington, D.C. area, you can go meet them in person. And do you do it virtually as well?
I'm virtual in 44 states.
44 states. Okay, great.
Yeah.
Okay, so let me tell you that she earned her doctoral degree in medical and clinical psychology at the Uniformed Services University of the Health Sciences at the F. Edward Herbert School of Medicine in Bethesda, Maryland. And she did a postdoctoral fellowship at the Uniformed Services University Center for Health Disparities and the Developmental Research Laboratory on Eating and Weight Behaviors, which is quite a feather in her cap. You know, our mission here is to give you the most up-to-date, accurate information possible and to dispel all the myths. And the only guests I will have on are people like her who are true experts. And she truly is and completely committed. In fact, we were just talking about just how important our work is to us, and hers is very important. She calls it our happy spot. Mm-hmm. That's what she calls it. And her real specialty, although she's very broad ranged, is the effect of weight bias and stigma on health. And that is something that we don't typically talk about when we talk about bias, and we know that it's there. And if you struggled with having obesity, you know the bias and the trauma, which she talks about. But the effect on health is something that's unique and not something we talk a lot about. So that's what we're going to be talking about today. And I want to say one other thing that, she has certifications in lots of things like treatment of eating disorders. She has an intriguing certificate in artificial intelligence healthcare, which I am a little curious to know what that's about. And in my 45 years of practice, I do not believe I've ever met a clinical psychologist as esteemed and accomplished as her, who is also a certified fitness trainer. So that's truly a feather in her cap, and she walks the talk. And so she's wonderful. A quick announcement that it is Luna's 8th birthday. That is Alex's, one of his 4 dogs. He has 3 Boston Terriers and a Frenchie and 2 cats. And so that's Luna's 8th birthday. So we wish her a happy birthday to Luna. And she's got a beautiful face and loves to kiss Alex. Okay, so if you hear 4 ruckuses from 4 different dogs during the podcast, it's Alex. And then finally, I'd like to call your attention to Dr. Pashby's book, The New Food Fight, How the Weight Management and Eating Disorder Fields Became So Divided and What We Can Do About It, which we will visit and get her comments on that. And then I saw her on a video online, which was what attracted me. something she calls What We Carry. And she shows up on this video. It looked like a TED Talk, and she's wearing a backpack, but it's like a suitcase. And she starts unpacking things and makes the metaphors about what's in the suitcase to what we carry with this disease of obesity. And it's a brilliant video. So in the show notes, you'll be able to see that. Okay, so welcome. And is there anything you'd like to say to introduce yourself, or
oh my goodness.
You're on the floor.
I'm so grateful to be here and to talk to anybody who hasn't sort of explored this part of obesity care. I think it's an under-discussed and critically important topic that we're going to talk about today. So thanks for having me.
You're welcome. Thank you for showing up. So I like to ask just what sparked your interest? What got you going on this? Because it is a unique, I mean, we can understand some compassion and empathy for people who struggle with a disease, a chronic disease, but you have taken it light years beyond that. What drove you to it? What keeps you going? What is it? Tell people.
Rich, it's so funny, Rich, because if you asked my family, they would say that I take everything to the next level because that's just part of my personality.
Well, that may be true.
So I think I don't do anything sort of small time. I'm a passionate human being in all aspects. So in this domain, I have personal experience with weight struggles my whole life. I have family experience, and I really importantly have, as I've grown and developed over the years as a psychologist, sat with literally thousands of patients in all different body shapes and sizes and health, that, levels of health. And I just feel like I am the vessel of their stories. And I just feel like it is my gift to other clients who I can't work with in my, office. I can't scale myself, right? And so what happens is I feel like, oh my gosh, there's so many people out there that could benefit from knowing this information, from sharing these stories, and I have them. And so that's what keeps me going. And that's where I get all my information, and my patients are the smartest people I know.
God, I swear to God, it's like we're looking in the mirror at each other and the vessels of their stories. Oh my God, that's like the title of a book. But you get it and becomes, I've been doing this 45 years and I can tell in 3 minutes whether somebody really gets it or not. And you do. And it's as clear as the day is long. And I would never have anybody working in transformation weight control who wasn't like that. So, you certainly fit that bill. So we were talking before the podcast a few weeks ago about the importance of not only being a clinician, but also doing research, which we both have done, and how the integration of that is so important. It's translational, we call it. You translate your research into your clinical care. Can you comment on that a little bit, how that's helped you and helped all of your patients and clients? Can you speak a little about that?
I respect researchers, people who do full-time research, just immensely. I mean, it is a very high stakes, high pressure role with very little sort of acknowledgement, right? It's often done really behind closed doors, and it doesn't often see the light of day. And I think that I was trained in a PhD program with a very strong emphasis in the scientist practitioner model, which means that you're trained as a scientist first and a practitioner second. And so I've approached my whole career from a scientist point of view. And I think that being able to read research in the area of obesity and then take that information and translate it, as you said, into how do you actually use this information in your everyday life between working and taking care of your kids or your dogs or whatever, right? Like, how do you actually use this data? That has been something that I think I'm really good at that. I think I'm really good at understanding the complexity of the research and then translating that.
And translating it, right.
Yeah. And so actually, Dr. Renee Rogers, who I know you're going to interview in a couple of weeks for your podcast, she recently published a graphic about like different types of physical activity and exercise. And I have it printed out in my office, and I'll like pull it up to with patients and say, look, like this is a visual representation of some of the themes that we've talked about over time. And I love to take science and use it to help people feel like they're they're on the right path in their health journey. It's just powerful.
That's terrific. That's great. We're doing a healthy aging workshop, and I really decided I'm going to give it to them really good. I'm explaining the molecular, atomic level parts of aging and what happens to your body. But like you, I can interpret the hard science into something very simple, like your body rusts.
Right.
That's how we put it.
And I think, I also think that because I've worked with thousands of patients, people are really smart. They really understand their own bodies, right? And so I want them to feel like they have the tools that it takes to go read the research themselves if they want, right? And then talk about it. So
when, for 25 years, I ran the program and developed it at the research center at St. Luke's in New York City. And my office was right across the room from where we would meet. And, I'm busy doing a lot of analyses on our research and things. And then I'm done with it. And I just walk right into the room and tell them, hey, listen, this is what's going on. This is what I just found. And then explain to them and teach them how to read the research, like you just said, because people just don't have the training and they can't interpret. Yeah, that's awesome. Your doctoral dissertation was on emotional eating. I don't want to go through your whole dissertation. That was 4 years worth of work. I can appreciate it. But could you just summarize it a little bit? I once had somebody say to me, it occurred to them, I'm an emotional eater. They never really it never dawned on them. And it was such an unbelievable observation. Could you just for a moment?
Yeah. So my dissertation really looked at, because of the type of program I was in, right? A very medically oriented program, a science program. My dissertation looked at the cognitive, the emotional, and the physiological impacts of eating during stressful events. So in a nutshell, I had groups of people, and some people watched a pretty stressful scene from it was actually one of those like after school specials. This dates myself, but one of those like after school specials about a very stressful domestic violence incident. And people watched that. And I was measuring their galvanic skin response, which kind of means like your sweat response.
Yeah.
Heart rate and heart rate variability and blood pressure over time. And then I was having people watch this, and some people were eating M&Ms and other people were eating grapes and other people weren't eating. And then we basically just looked at outcomes, like what does eating during stress do for people? And so my whole hypothesis, not surprisingly, was that we would see this sort of dose response relationship where people would get kind of like a blunted impact of the stress when eating high carbohydrate foods. And that is kind of what we saw. And so I use that still as just like ammunition to remind people that their behaviors make sense, that it is not like emotional eating is a very highly adaptive thing that humans have developed to do to protect ourselves. It helps us experience stressors in a blunted way. It helps us not maybe get quite as anxious. And so why wouldn't we do it? Well, of course, we understand that when you do it over and over and over and over again, it has some health impacts, right? But if it didn't, it would be a genius way of managing your physiology. It's not hurting anyone else. It's private. Like there's all these really positive things to it. So I just don't believe that people do things that don't make sense, right? Like there's a function behind all of our behaviors. And so I still look back at my dissertation as me sort of being that person that wants to say, look, I get why you do these things. I get why all people do things. And why don't we figure out like, yeah, this is serving a purpose. So I can't set a goal to just stop emotional eating without deciding that I'm going to do something else to help manage those feelings or those stress responses and things, right? Like that it's a process to unlearn. But I think where I really was going, Rich, is I was trying to get people to start dropping some of the shame, right? Like if we see that this behavior affects our biology and our physiology, then maybe we can stop saying, well, what's wrong with me? Why am I so lazy that I always eat when I'm stressed? Maybe we can say, oh, my body is telling me to do something because it makes sense.
Yes. It's like explaining to people that this is not their fault. Alex, go ahead.
Quick question. So does that mean that every now and then you should eat whatever you want and not really care?
So I think that's a really important and loaded question, the way you framed it. And I'm a psychologist.
Well, only because yesterday I had one of those days where I had like 4,500 calories.
Mm-hmm.
Wasn't the plan, but that's what I ended up doing.
Right.
And I have that all or nothing thinking. So
Here's the question, Alex, right? And because patients will ask me questions like that all the time. And I always say, first of all, when you say, should I just eat what I want to eat? I always say, well, what do you want to eat? Because I heard you say, I didn't want to eat that. I ended up eating it, but that was not my plan, right? So first we go after like, well, what do you actually want to eat? Then we ask, why do you want to eat it? Is it because you had a really stressful day yesterday? Is it because your colleague was annoying? Is it because you got in a fight with your friend or your sibling or something? So we look at those things. And then we look at, what are your health risks? What is your mental health profile? And what are your goals? Because truthfully, if you're healthy, if your mental health is pretty good, and if you ate 1,000 extra calories yesterday because you were in a bad mood and you normally don't do that, who cares? Who cares? But if you're a person who has very sensitive blood sugar regulation issues and you're living with obesity and you're really, really struggling with depression and anxiety, and you find yourself sort of in that pattern over and over and over again, every day after day, then we have a really different conversation, right? So I always like to take that example and say, well, that's like a snapshot, and we can never generalize based on a snapshot. It's part of a whole picture.
All right, that makes sense. Thank you.
Yeah.
And intrinsic to your answer, underlying it all, is there's just no judgment whatsoever.
Yeah.
We can't in this business do that. If we did, we wouldn't be in business. And people sniff it out immediately if they feel that you're judging them. And it's obvious you're not. And the point of explaining to people the neurobiology, the brain biology, how, as I say it all the time. Nobody woke up one day and thought how cool it would be to struggle with their weight and addiction to food and people need to understand that, but they buy the bias and the stigma that has been loaded down on them.
Yep.
Right.
Exactly.
Yeah.
Exactly. And I hear it when people, not only when people come and tell stories like Alex, like you just told, right? Because it sort of assumes that you were bad. It assumes that you made a bad choice or that you were weak-willed or something, right? It's sort of baked into that question. But I also hear it when I hear people talk about like their goals, right? Like, my goal is to never emotionally eat. I'm like, well, but emotional eating, I mean, if I say birthday, you think cake, right? Like it is part of being in America. So maybe we need to set goals that are gentle and realistic so that you can actually meet them and rebuild that like self-integrity that so gets depleted over time and just hurts.
Yeah. I've noticed when I suggest to someone, listen, you're going away for the weekend, your wedding, enjoy yourself and have what you want. Yeah. And you know what happens every time, and I'm sure you've seen the same thing. They come back the next week and they say, Rich, I listened to what you said. And guess what? I did eat what I want, but I didn't eat as much as I used to because I gave myself permission and it was okay. And I wasn't judging myself or beating myself up. I had self-compassion, which I think is exactly what you're saying.
I tell my patients, I love visuals, as you probably know from watching my talk. And I tell my patients that restriction is like handcuffed to binge eating.
Terrible.
And the more you tell yourself, I shouldn't do that, what's wrong with me, I need to stop eating, the more your brain goes that direction, the greater the rebound into the other direction. So I always say, try to let those go.
Right. God, we have so much to talk about. I want to revisit one thing you said that I think is important, and I ask it on behalf of the listeners, which is, you're getting a secondary gain from the emotional eating, and we don't have a problem with that, and we understand it and so forth. When you alluded to this, when you stop doing some of that, or you get more control over it, maybe is the best way to say it. We call it filling the void. What do you do with all those feelings that the food was taken care of for you effectively. We call it filling the void. How do you handle that with folks? So, okay, if I'm not going to have all this emotional eating, I'm going to eat what I want, but it won't always be emotional. What do you do? I'm anxious, I'm depressed, I'm this, I'm that. What do you do?
Yeah. So, I mean, I think that the go to answer for most people is, well, let's build other coping resources. And that's a good, solid response, but it is an incomplete response, right? So, building solid coping resources means like the basic stuff that we all know, right? Figuring out other ways to manage our stress that might include things like going for a walk, or getting time with friends, or talking to a loved one, or seeing a therapist, or taking medication, making sure that your sleep is on point, getting time outdoors, finding hobbies that you enjoy. I mean, the list, right? We could sort of all create that list easily. That is important. And I do not want to minimize that, because you can see real changes in people when they do invest time in those things, right? I do all of those things myself too, because I believe in them. But more importantly, I think, and this is where the psychologist in me comes in, I always think, what is the root of all of this struggle? Because unless we go upstream of the struggle, we're going to sort of keep going down that same path, right? So if a client comes to me and says, like, I find myself emotionally eating or binge eating or having loss of control over my food, over the course of time, what we uncover is that actually I'm in a really unhappy marriage. And every night after my partner goes upstairs or whatever, I find myself sort of like pacing through the kitchen and eating. I mean, we can build coping resources and it will help. But at some point, we need to address the root of the issue, which is the really uncomfortable stuff, right? So it might be addressing the dynamic in the marriage. It might be addressing undiagnosed ADHD that is causing people so much anxiety because they're constantly behind with work demands. It might be addressing childhood trauma that has never been addressed. So there's so many things that are upstream that contribute to why people need all of this coping. I want us, and I believe in developing coping skills, but I really think that a lot of the stuff is upstream, and that's where it's a little more complicated.
And do you find that people are amenable to that approach, the coping skills they get, and you go through that with them? You maybe even
Right.
you can have a handout of them, but
Right.
are they then amenable to that sort of exploratory investigation of their own psyche and experience?
Yeah, so I mean, I get a biased sample of people who know I'm a psychologist and come to me, right? So I think people in general are a little open when they come through my door. That said, the timing of this, Rich, can vary from, there's some people, and I think you said earlier, like, within 3 minutes, sort of whether someone's like with you, right? I know I can sort of suss out like where a patient is in
Right.
minutes. And some people are maybe telling me outright, maybe not, maybe I feel it, that they need time before they're willing to go there. And that is
Right.
perfectly okay. Other
Yep.
people come and say, look, I know that all of this behavior is because of that thing. And I'm finally ready to tackle that thing. Right. And
Right.
so, yeah, I
Yeah.
mean, some people are more open than others, but I think we get there.
Yeah. No, I mean, if you start sounding like all the other weight loss programs telling them what to do and you're supposed to, it's never going to work. You'll
Yeah.
never build trust. It's different, right?
Yeah.
All right. So before we do get to the trauma and your book and your video, very briefly, obesity as a chronic disease. What are your thoughts?
Well, that's a fact. So, I mean, I believe in facts and science. So, obesity is a
Okay.
chronic disease. That said, I will acknowledge that the mental health side of obesity is something that is often lost in a discussion of the chronic disease model. And that is true across many chronic diseases. So I did so many rotations in hospital settings and other things. And I worked in oncology, I worked in HIV AIDS, I worked in renal dialysis centers. So I worked with patients living with a lot of different chronic medical conditions, some like ALS and Parkinson's, some very progressive and ultimately fatal, and others more just long-term management. And almost all chronic disease share the gap in recognizing that mental health is a serious component of living with a chronic disease, right? And so obesity is not special in that regard. It's just that it is visible. And so people living with, for example, like lymphoma can walk around every day for the most part and no one knows. Not so with obesity for the most part, right?
Right.
And so we run this sort of different experience where you live with this chronic disease that people know you have and make all these judgments about it. And so that's where it's a little bit different. But in general, chronic disease don't value mental health the way they should.
Yeah. And your point is so well taken about, like, blood pressure, the silent killer. You can have, nobody talks about blood pressure or diabetes, or any other chronic disease the way they talk about obesity. It's like they just think, eat less, exercise more. It's not a disease, and we're fighting this uphill battle. I've been fighting it for decades, really, convincing people that this is, and you're spot on with this. And I think, people have said to me, don't do that. It's going to only make people think that they have some disease or something. But it's not that. It empowers them. It helps them understand that this is no different. Years ago in diabetes, we learned, it was hammered into us, you never say to somebody they're a diabetic, because then they define themselves as, and they're not their disease. And now, as you know, we don't say you're obese. We say you have obesity because it's a disease. And that's the direction.
Yeah.
We're right. Yeah. What about food as an addiction?
So, I mean, I have clients for sure that have food addiction, and that's their lived experience with it. And I mean, knowing enough about the neurobiology to know that we have real brain reward systems that are activated by food. And so in the same way they are activated by other substances of abuse and dependence, it is really tricky, of course, because the primary treatment model in addictions is abstinence.
Abstinence, right.
And so that's what a lot of these like VLCDs have been over the years, essentially, right?
Can you just tell people what a VLCD is?
Yes, of course. A very low calorie diet. So it's these full like liquid meal replacement programs and things like that Dr. Frank, used back in his clinic years and years ago. And by the way, like have good data behind the medical outcomes, strictly medical, right? When people use them, sometimes they have improvements in their medical conditions. But of course, we forget about the mental health side of it, of course. And nobody can remain abstinent of food forever. And so learning how to care for food addiction is complicated.
Yeah. I like to say to folks that, there's bad news and there's good news. It's an addiction like others. However, it's also something that you can learn to control. And, if you have a cocaine addiction, you can't really just have a line of cocaine every once in a while or a shot of whiskey. Right. But you can learn to enjoy food, and that's the good news, and we can help you do that. Right. That's sort of the message. You use the term reward systems, and I talk about it. We talk about it all the time. I'm not sure everybody always understands what it means. Can you just speak for a moment? Just what is the reward system that's driving this? Because that's at the heart of this. And so I think it's important for people to understand what's going on. Could you just...
Yeah, so I mean, there's lots of brain regions involved in the reward system. I always think of the nucleus accumbens and the ventral tegmental area of our brains. Right. These nuclei, these little groups of nuclei in our brains that really respond favorably. They make us feel pleasure, right? When certain conditions are met. And that is, people really do understand that when we think about like gambling, right? You could sort of like that little high you get if you win on the slot machine or if you take a drag of your first cigarette, right? Like those reward systems get activated. And I mean, I'm sure you've read, Rich, over the years, so much information about how food is bioengineered. These, processed foods are
Ultra
bioengineered,
processed.
right, to really activate the reward pathways for people. And
Right.
so we are having brain activation that tells us this is pleasurable a lot. And then we want more of that. I mean, screen addiction is very similar in that way, right? It's like
Which
very
addiction?
screen,
Oh, yeah. Yeah.
right? Because the games and things are designed to activate reward centers in our brain.
Right.
And you
Yeah.
kind of, it's normal to want more of that. So
Right.
we have to sort of, again, see it as like, this is your brain doing what it's designed to do, which is to seek
Exactly.
pleasure.
Right, exactly. So I show images of brains lighting up when people are subjected to an image, let's say, of their substance of abuse. And I say, if you feel like your brain's on fire or lighting up, well, it is. It's
It
like these
is.
little chemical messengers, these neurotransmitters are sending signals down this pathway. It is a pathway. And so people can understand, okay, and it reaches, the nucleus accumbens and it reaches the pleasure center where I really get the boost.
Right.
So, and people warned me too about that too. They said, Rich, if you start telling people they have an addiction, they're going to see it as a negative. I said, no. You're completely wrong. You're wrong. I don't even talk to anybody about it because they're wrong. It empowers people to understand what's going on and get control of this thing. This is
And also,
not their fault.
Patients tell us. It's like, I'm not telling my patient anything. They know,
Yeah,
right?
they know. Exactly. Exactly. No, I agree. Like I learned a lot more by listening than talking. That's for sure.
100%.
And I got a shelf filled with books. None of it has that stuff in it.
Yep.
Right. Exactly. All right. Good. So we have established that we are on exactly the same page on everything. So let's talk for a moment about your book.
Yeah.
I'll name it again. The New Food Fight: How the Weight Management and Eating Disorder Fields became so divided and what we can do about it. And you did it with a few co-authors. Tell us about the book and what's the takeaways from it? Why should people go out and get this book and what are they going to learn? And tell us your stuff.
So we do a couple things in this book. One is we share some personal narratives because I really do, we decided as a team that we really did want to sort of set the stage. Like, this is something that matters to us. Like, we're not just writing this because it's hip to be in the obesity space right now. I've done this work for 20 years and my colleagues, some are even longer. And so we really wanted to sort of show we come at this from the right place because everybody and their brother is jumping into the obesity space right now because of these new medications, new in air quotes.
Right.
And so we start out with the personal narratives and then we sort of break down several of these divisions. And honestly, how this started, Rich, is I advertised on my local area therapist listserv, which has thousands of therapists in the greater Washington region, Maryland, Virginia, West Virginia, like Pennsylvania, lots of therapists. I advertised that I was going to run a weight management group. And I was asking if anybody had referrals. And moments later, a reply all to thousands of therapists came. And it was a full out attack on me, saying that I was giving people eating disorders and that it went on and it was terrible. And I had to scrape myself off the floor. I was blown away. And that was my not so subtle entry into, and I was young and naive in this space at that time. That was my not so subtle entry into the division that psychology in particular had been growing over time. And as we dug into this topic, and so basically I went to some of the co-authors on my book when this happened and said, you guys, what just happened, right? Like I want to help people. I have skills that can help people. I'm not preaching restrictive diets or anything like that. Like, I'm not part of the diet culture, right? And my colleagues shared that they had similar experiences over the course of the next several years. And so we decided, you know what, like, this is a thing. We should know more about this. And we started researching. And basically what has happened is that there are these two silos in the psychology world in particular: eating disorders and obesity. and the two do not cross. And
Right.
that is driven by funding mechanisms, right? There's like a place you go to fund eating disorder studies, and there's a place you go to fund obesity studies, but you don't cross. It's driven by food marketers, it's driven by pharma industries, all these places like way higher pay grade than me that sort of trickled down. And so in the book, we really talk about what a horrible disservice this divide has done to so many people who live at the intersection of high weight and disordered eating. And I think that there's this bias in in obesity treatment world, that if you're talking eating disorder in people living with higher weight, that you're talking about binge eating, because they think, oh, well, of course, you must eat too much, right? So that's why you have obesity. And what we've actually uncovered, of course, over time is that there's binge eating, but there's also binge eating in people that do not have obesity. But
Correct.
there's also purging. There's also intense restrictive eating disorders. There's atypical anorexia. There's ARFID. There's all these other disordered eating patterns that show up in people, night eating syndrome and things that are completely missed so often because of bias. Because people who see someone living with a larger body don't think to ask. And we just had enough of that. So we decided to write this book.
That's terrific. I like that you draw a distinction, at least I hear you. I think you're saying there's a difference sort of between eating disorder and disordered eating.
Yes.
And people don't differentiate that. And I do a lot, and it sounds like you're, again, right on the same page, that there's a big difference.
Yes.
There's a big difference. Yeah.
There is. And I think the other thing that people don't really realize, especially people in the weight management world, right, or the obesity treatment world, I don't think that there's awareness of just how damaging eating disorders can be. I mean, they have a very high lethality rate. They are associated with serious depression and anxiety and loss of functioning.
Yep.
It's really dangerous.
Yeah. I worked for 25 years at the Obesity Research Center. It was the first obesity research center in the country funded by NIH. And we had a Friday conference every Friday. And sometimes we would bring in folks who were experts in anorexia. And I was thinking, what are they doing here in a way? Because it gives the impression that anorexia is the opposite of having obesity. And it's not. There's nothing. It's not like, it's just not this. It's the opposite. But there's an impression that it is. And that's exactly what you're saying. Okay. Yes. All right. So thank you. And I think everybody should really just go out and get this book.
Everybody should read it.
Everybody should read it. And we will put it in the show notes so they can find it. Okay. I want to switch to your video, What We Carry. And just to paint the scene, here she is, Dr. Pashby, on the stage looking like a TED Talk with this, I don't know what it was on your back, a suitcase or something, but it had straps and everything. Tell the listeners. What is that about, What We Carry?
So I have given a lot of talks over the years, and by far, this is the talk I have the most pride in.
Well, it's great.
I was so nervous. I was talking to Dr. Bob Kushner the day before the talk, and I'm like, Bob, I need a pep talk. I need a pep talk because I was so nervous. I weighed myself on stage. I know. So this talk has been brewing in my mind for years, this idea that I wanted to do something different, and I wanted to share this story of what it's like to live with the shame of obesity, not just obesity, right? Because, and I wanted to be really careful not to mimic what so many horrible things have been done over the years, like people walking around with those heavy suits on to mimic living with obesity and things.
It's the worst.
It's the worst.
The worst.
Yeah.
I know. I agree.
So I was really careful to say, like, this is about what we carry that was never ours to carry, right? And in the backpack, and of course it was a big play on words because I'm a psychologist and I like to unpack things with people. So it was a sort of a play on that idea that And in the backpack, I had a variety of things to represent some of the most common themes that come up in our therapy sessions. So things like shame, things like perfectionism, things like self-doubt, things like erasing ourselves from our lives, right? Like never being in family photos or pictures on vacation, not showing up at events like class reunions or family weddings or family reunions, and all because of the dissatisfaction and the shame we have around our body shape and size. And so I tried to reflect all of these different aspects of it. And the response has been like way more than I could have ever imagined. It's pretty awesome.
Just to paint the picture for people, here she is on stage and she's got this backpack suitcase thing, and she's taking things out one at a time. And like she took a scale out and she said, look at this. And then she puts it down on the ground, and then she takes something else out. And it was brilliant. And again, we will have it in the show notes, but what we carry, just Google it, you'll find it with her name, and it's definitely worth a watch. So you got a great response about that, I guess.
Yeah, thousands and thousands of responses. It's shocking to me. Yeah, I mean, I'm you know.
So I hate this kind of question, but I'm going to ask you anyway. Of all the things in that suitcase, what do you think was the most damaging? Can you say or not?
I mean, I think it depends on whose story you're telling, right?
Okay.
My story is not, my next door neighbors. And so I can tell you that out of that backpack, that my most damaging moment is where I started, which is when I was weighed in third grade and was told my weight, or not even told my weight, but the gym teacher who was weighing me in front of all my classmates said my weight out loud to the nurse who was dutifully jotting it down on this piece of paper. This was just standard procedure, right? It wasn't like they were doing anything wrong. They were doing what was the standard protocol. And I remember in that moment very vividly thinking, wait, why do I weigh that? And my friends don't weigh that. And in that moment, it became really clear to me that that was not good, that there was something wrong with me. And that stayed with me a really long time. And if I'm not careful and I'm not working on my mental health, that can come back, right? And so notice that I'm not saying working on my weight. I have to work at the mental side of this as diligently as I, do yoga or whatever else I like to do for exercise. So that's my most damaging thing, but everyone's story is so different.
Yeah, I agree. Right. Yeah. I mean, I'm thinking, I remember once I live in New York City, near Central Park. I was walking through the park and I was watching, there was a girls' school group out in the field, and they were doing the classic horrible thing about physical education. They were picking sides for the team. And I was watching this, and I just knew, you could see the anxiety in the girl who was tears came to my eyes. You could see it in her. They were like 12 years old, maybe something, I don't know. But she had grown very tall very quickly, and her motor development just didn't keep up with the growth rate. And you could see the anxiety because she knew she was going to be picked last. And it was so painful to watch. And the simple answer is the teacher just assigns half the kids to one group and be done with it. So this is the perfect segue. I want to talk about the effect of stigma on health, but before we do, I think this is the segue to trauma as a child, or even as a young adult, if the disease of obesity afflicted you only as a young adult and not as a child. But my take is this is like PTSD. This is trauma. I have done research on sexual assault in this population. I don't know what to ask you first.
Yeah, let's talk about it.
Let's talk about it.
I'm very careful to distinguish that there's lots of different trauma associated with obesity, and there's pretty robust research, as you know, in adverse childhood experiences, which are living in family environments where a child is maybe the child of a parent with severe mental illness, or a parent who gets incarcerated, or there's a lot of violence in the home, or various other types of traumatic experiences. If a person experiences verbal, sexual, emotional abuse or neglect as a child, these are what are called adverse childhood experiences. And what we know is that as the number of adverse childhood experiences that a person has in their life, the risk of their weight going up, it just magnifies. Well, I think I remember a statistic properly, something like for someone who has 6 or more adverse childhood experiences, for every
Yes.
adverse childhood experience they check off, their BMI rate goes up by 1. So
Yep.
we're like, it's literally a dose response relationship. And so adverse childhood experiences are very significant predictors of adult obesity, but also of depression and substance use and other things. But then there's also the trauma of living with obesity. And I think that that's something that is under discussed, but highly relevant to the treatment of obesity. Because not everyone living with obesity had an adverse childhood experience, but almost every single person living with obesity has a traumatic story like mine, or like that little girl in Central Park, or the thousands of other stories I've heard of people, being teased, bullied, shamed, physically assaulted because of their weight, and excluded from things, right? Outright neglected, locks put on refrigerators, families who don't invite their child to a dinner because they don't think the child needs it, like asking the child who has the higher body weight to leave the table. Like the number of traumatic experiences that a person can have because they have obesity is so relevant, because that over time, we simply cannot experience that level of traumatic stress without internalizing that level of traumatic stress. And that does several things. Number one, it affects our cortisol response system, and it just sort of like becomes this accumulating stressor, right? And stress response, which we know is terrible for our health. Number two, it can cause us to try to do things to manage our weight in unhealthy ways, like develop disordered eating and other things, trying to over restrict or trying to purge, or ways to try to reduce our weight. But then also it impacts people's willingness to seek treatment and care. So we now have treatment options available for people, and so many people don't feel worthy of getting help because they have internalized, this is all my fault, right?
Exactly.
And
Yep.
so because this is all my fault, I don't deserve treatment because I just need to, quote, get my act together, or put on my big girl pants, or whatever people's slogan is, whip myself into shape. There's just like so many little slogans that people use. And so the traumatic experience of just living with obesity is something that we have to address in order
Right.
for this treatment to actually stick, I think.
Yep. Yes. One of the things that just strikes me so incredibly is how long people have carried this trauma, even if it's not an adverse childhood event. Even it's just the trauma of living with obesity as a child, where, if you ask the child, would you rather lose your arm or have obesity? And they would rather lose their arm.
Right.
And there's been research like this. But
Right.
for how long they've carried it as a secret, and
Yes.
not told a spouse even, or a therapist, or anybody. And you have a 60-year-old person who has been scarred their
Yes.
entire life by this. It has had to have a
Yes.
profound impact on their
Yes.
whole psyche and everything. And I'm sure you must see that all the time.
Of course. And I just have to say, this is where I got the name What We Carry, because what you just
Yeah.
said, right? People carry these stories with them
It's
their
a
whole
strike.
lives. Right.
Yep.
And so, and I mean, I have clients that are dying of cancer and will say to me, well, at least I'm thin for the first time in my life.
Yeah. No,
Right.
I know. So can you make progress with these folks with this kind of trauma? Because I have heard multiple times, Rich, you're the first person to have ever asked me that question.
Mm-hmm.
And no one ever asked you this before?
Yeah.
No,
Yeah.
It's been such a disservice. The programs, they haven't failed the programs. The programs, their doctor, they've been failed by the system.
Yes.
Do you help them? I refer them for help, but you've found
Yes.
that you can help them.
Yeah. So, I
it
mean,
doesn't go away. You don't erase it.
right. And so there's like, again, and this is where the distinction matters so much, because we have very effective trauma treatment modalities for people that have adverse childhood experiences, or for people who experience traumatic events, not specifically like teasing or bullying, but really traumatic life experiences, violence and things like that. We have very effective trauma treatment. And that is one avenue. But we
Yeah.
also, where I specialize, is in working with this internalization of the bias and stigma that becomes self harming. And I don't
Right.
mean cutting, right? But I mean sort of like this constant negative self evaluation.
Yeah.
Um, and what I try to remind people is that if people have repeatedly tried to lose weight and what they would say is failed, right, because their weight came back, I always say taking a different path, like weight management needs to come second to managing this internalized bias, because
Right.
otherwise we're sort of like playing the same song on repeat. And the whole point
Yeah.
is to move on in the album, right? To like get to the
Yeah.
next song. And this is a different avenue. And so I see really effective progress for people when they start, number
Good.
one, recognizing the intensity, like, oh my gosh, I can't believe this has shaped so many decisions in my life, right? I didn't go for the promotion. I didn't ask that person to the prom, whatever it is, right?
Right. Yeah. Okay. So for the last 10 minutes, we're going to talk about your real specialty, the effect of all this stigma on health. I wanted to just tell you very quickly that when I was doing the research on sexual assault in this population, and it was about 30% of the people who revealed that this had happened to them, sexual assault. And what I found was, yes, they weighed a little more, but they also dropped out of the program more
Yes,
frequently, which I
yes.
thought was a really interesting observation. And it was very clear. It was clinically and statistically significant that folks who had reported, and I'm just talking about just sexual assault, not physical or any other kind of assault. I mean, well, sexual assault is physical assault, but yeah, it was an interesting observation. I thought you probably would be interested.
Oh,
That's what I
yes.
found.
Yes.
Yeah, they really clearly dropped. So we worked on that. And this is a perfect example, frankly, of translational research. It's like I learned that there's a high probability that you may drop out if you tell me that you had a history of sexual assault. So I can do something about that now. We can help you because it's a predictor. Yeah.
Right.
Okay.
Exactly.
So let's switch. So I guess we should say before we move on, anybody who has had any of these problems, sexual, physical, emotional abuse or assault or any, what resources, where do they go? If
Hmm.
we can just very quickly give
Yeah,
people
no,
an
that's a
outlet for
great
this.
question. Yes, so there's lots of different trauma treatment programs available. Some of them take insurance, some of them are private pay, and people can certainly look on things like Psychology Today to look for trauma
Okay.
treatment programs. That's like the most sort of universal place.
Psychology Today.
Yeah, that's a good
Okay.
standard spot. But also, I mean, you can talk to your doctor, your primary care provider, assuming you have a relationship with that person, about a referral for a therapist. And you don't have
Yeah.
to disclose why. That's your
Hmm.
private health information, but you can ask for trusted referrals in your local
Yeah.
community. That's another good
Yeah.
thing to try.
Okay. It was, and then we're going to move on. It was striking to me how women who were reporting this, I said, your gynecologist never asked you about the possibility of sexual assault? Your pediatrician when you were no doctor, they would say to me, you're the first person to have ever asked me. I was stunned. So I want people to know that there is help. So I like
Yes.
the Psychology Today thing a lot. And thank you.
Yeah.
Okay. So let's, for the last 10 minutes, talk about you have 100 reasons for being on this earth. You were put here for everything you do. Talk about the effect of all this stigma and all this bias that we cannot ignore on health. I'm going to
It
just let you take it away.
starts. I gave a talk at the Obesity Society meeting maybe 5 years ago or something, and I showed pictures of how internalized bias is with a person from the moment their alarm goes off in the morning. So the alarm goes off, and the first thing in someone's mind is, why did I eat that last night? Or I, today is going to be a new day. Today is going to be a better day. I'm going to be good today, right? And throughout, then they get dressed or take a shower and they're looking at their bodies in the mirror, or they're avoiding looking at their body in the mirror. And I just sort of took it all the way through to the very last thing at night. They lay their head down on the pillow and think, why did I do that today? Tomorrow I'm going to be better. And the cycle begins again. And I think of that story as like little mini crises all day long in your mind, right? And the thing that's so important that people don't realize is that our body's nervous system is not designed for that level of nuance. Like our bodies are designed to respond to keep you alive, basically. Like if we get really reductionistic about it, our whole sympathetic nervous system's job is to keep you alive, right? To help you flee the scene or fight back or protect yourself somehow, right? And imagine if you were like in 87 car accidents, just a little bit, right? But like all day. Imagine what your body would feel like by the end of that day. Just like sort of that surge of adrenaline and cortisol racing through your body. And people sort of get that, right? Like, or what if you had the worst day of your life, but you got that news 40 times in one day, and then the next day, and then the next day. You think about how physiologically draining that is for people, because you have this system that is designed for acute stressors. And yet, when you have internalized this bias, you are constantly experiencing a feeling of failure, which tells your body danger, danger, because people don't like to fail. It's not safe, right? So you have the system that's designed for survival, and we are constantly threatening it by this internalized bias. And therefore, the health outcomes are exactly what you would imagine: high blood pressure, chronic headaches, chronic pain, digestive issues, weight gain, sleep disturbance, depression and anxiety, of course. The list goes on and on. Hair thinning and falling out. I mean, when you think about like chronic stress like that, people forget that. I mean, they think about the chronic stress in their lives, right? Like, oh, the work deadline or the sick parent, but they forget about like what the internalized bias every minute of every day is doing to our bodies. Right. And we don't have any room to handle the other big stuff that comes our way, because our nervous system is maxed out already.
Yeah. Yeah.
So what do you do in this case? Because I mean, I get up in the morning and I'm like, oh yeah, I'm going to have a good day today. And I actually keep a log of good days and bad days. Mm-hmm. And I try to stack, as many good days as I can, but there are occasional bad days there as well. Like, yesterday wasn't planning on eating 4,000 calories, but I did. So what do you do in those cases? I mean, I can't say that I have high stress or any of the symptoms except for the high blood pressure that you mentioned, but just out of curiosity.
Yeah. So, I mean, I don't usually talk in terms of good and bad days. I talk about like people's behavior overall. And I actually really encourage you to think about letting go of the good and bad and looking instead at the why and the what next. Because good and bad is like so subjective, right? If your goal were to gain weight, if your goal was to manage your emotions, if your goal was to have fun at the birthday party, you probably achieved all those goals. But if your goal is to lose weight and you ate that, then you probably feel like you didn't achieve that goal. But it's like totally subjective, right? Like you did achieve some goals. You probably felt less stressed by eating whatever in the moment. So I think that like assigning a value sets us up to just feel terrible. Instead, I always think like, okay, what are the functions? Like what are my intentions? How do I work to get there? And if things don't go as intended, then what do I need to do the next day to try to sort through that? But this is where the pillars of any mental health program come into effect. Because what I was sort of talking about when I was talking earlier is I think of our stress levels, like picture, if you will, a graph, a line graph. There's like a baseline level of stress on a 1 to 10 scale. Maybe you're functioning, Alex, at like a 3 baseline. Not very stressed, but also not like laying on the couch all day, every day doing nothing, right? Like, so kind of in the middle, like pretty low end middle. And then you go out to your car to go somewhere and you have a flat tire. Darn it, your stress goes up to a 7 because you got to be somewhere and now you're going to be late and it's expensive and all those things, right? But over time, your stress level comes back down. You get it remedied. You kind of go on about your day. You're back to a 3. I'm talking about the 3. For my patients that live with this internalized weight bias, they're not at a 3. They're at a 7 to start their day. And then their flat tire thing happens and they lose it, because they sort of go over the threshold, right? So we're all going to have the flat tire or the crappy boss, but not everyone has that baseline that is so elevated by this constant shame, self-blame, self-criticism, world criticism. And that's the work that I do. So I hope that I can help people lower that baseline so that they can navigate the sort of normal life up and down that we all have to navigate.
Makes sense.
Nicely put.
Mm-hmm.
It's the absolute truth. Yep. I think you spoke to everybody who's listening to this, because it is.
Yes. Yes. From the first thing in the morning to the
Yep.
last thing at night.
We do a timeline sometimes with folks. We say, okay, I want you to identify the moment during the day when that food craving started to really heat up. Okay, great. But what was going on, and what preceded it, and what was it? And let's really do like an autopsy of your day to get to the root of the thing, just like what you're describing, because it's never one simple thing. And there's this baseline of, I'm a bad person. This is my fault. I have the guilt. I have the shame, the blame, the body shaming, everything, the whole ball of wax. But I think we want to let people know that there is help for this, that
Yes.
to first identify, this is what's going on. This is not my fault.
Right.
And my parents blamed me. Everybody. I went to the doctor before I stepped on the scale. The doctor slid the weight thing all the way over to the right. Like, I didn't have a gown that fit me. The blood pressure cuffed it. It just, the shame was everywhere all
Nowhere to
the
sit
time.
in the waiting room, right?
Right. Nowhere to
Yeah.
sit. You know, it just,
I know.
I tell you, and you're going to be coming back on, because we're going to talk about life before and after GLPs next time.
Oh, yes.
But I have stopped, because we're just about out of time, and Alex has a hard stop tonight at 7. But, 45 years I have suffered along with these folks.
Mm-hmm.
I have. And to see what's happening now with the new GLPs and the life-altering effect. So you're gonna come back on. I'm twisting your. I'm coming down to Washington, and I'm gonna drag you to the camera, and we're gonna have a whole conversation just about that, because I could speak with you for hours.
Yes.
So we didn't even touch on that yet, but I think that's something that also needs to be addressed.
For sure.
All right. So in conclusion, is there anything that I think you really kind of summed it up just there, frankly. The baseline is probably the answer to the next question, which is there anything else or anything you want people to take away from this that we haven't already said or repeat?
Just that I'll use the title of my talk. What we carry when we live with obesity is so much more than adipose tissue. And I want our treatments to reflect that complexity.
Okay.
That's all.
Great. Well said. Okay, we do need to stop. And if Alex leaves, I have no idea how to run this thing. So we have to stop.
Thank you so much.
Yeah, it is a pleasure and a privilege to have
Thanks.
you. You're so enlightened and so smart and so committed and just such a joy. It's just, I hope 1 million people contact you as a result of listening to this, and because you have the unique ability to really heal people from all of this, and it turns you on, and as you said to me, it's your happy spot, and it oozes out of every molecule of your body, and people would be well served to seek you out, and we will put your contact information and everything. So I'm going to have you back.
So send them our way. Yes.
That's fantastic. Okay, a quick plug for Transformation Weight Control for the program I started, and we're running a GLP weight loss medication support group, the only one in the country, and people are learning how not to have side effects and avoid all that, and how to really eat with these things. There was a paper showing 25,000 visits to the emergency room secondary to side effects of the GLPs. We've been doing it for 20 months. We have not had one person go to the ER, because we are providing the highest standard of care. People showing up once a week for 75 minutes with 20 other people and 2 healthcare professionals who know how to deal with this thing. So I am going to have you. You have no choice, actually. You're coming back.
I'd love
But
to.
it has
Thank you
been
guys so much.
It's been such a pleasure, and you're far and few between. There are a few like you, and I'm in awe, and
Thank
I
you
really
so much.
appreciate you making this great. So thank you.
Good night, everybody.
Okay,
Thank you.
Alex.
Good night. And we're done.
Awesome.